Let's talk about chemotherapy in a simple way, so you can get the basic idea of how it works. Chemotherapy started back during World War I, in 1917, when mustard gas was used in biological warfare. This gas caused severe skin burns, eye damage, and problems with the bone marrow, which makes blood cells. In 1944, doctors tried using a type of mustard gas called nitrogen mustard to treat lymphoma, a type of cancer. The patient had a brief improvement, but unfortunately passed away due to bone marrow failure. So, chemotherapy is a treatment where doctors use special medicines to kill cancer cells. These medicines can work on both the original cancer and any cancer that is spread to other parts of the body. Chemotherapy drugs work by targeting different parts of the cell cycle, which is the process by which cells divide and grow. Here are the main ways chemotherapy affects cancer cells. Changing the chemicals in the cell's DNA. Stopping the cells from making DNA or RNA, which are essential for the cell to grow. Interfering with how cells divide. However, chemotherapy isn't perfect. It doesn't only target cancer cells. It also harms healthy cells that divide quickly, like the ones in your hair, bone marrow, and digestive system. This is why people often experience side effects like hair loss, fatigue, or digestive problems. Because of these side effects, doctors have to carefully manage the doses and give time between treatments to allow normal cells to recover. Chemotherapy is usually given through an intravenous drip, and it's often a combination of different drugs. Each treatment cycle lasts about 3 to 4 weeks, and you typically go through about 6 cycles. The goal is to damage as many cancer cells as possible while giving healthy cells a chance to recover. Now, when doctors give chemotherapy, they base the dosage on the patient's surface area, which is calculated using height and weight. They also need to keep an eye on the patient's overall health, especially the function of the kidneys, liver, and bone marrow, because these organs help process the chemotherapy drugs. A key part of chemotherapy is something called pharmacodynamics and pharmacokinetics. Pharmacodynamics is how the drug affects the body, and pharmacokinetics is how the body processes the drug. Both are important to know because the drug's effectiveness can depend on the person's health and how their body clears the drug. One of the challenges of chemotherapy is that cancer cells can sometimes become resistant to the treatment. This can happen in 2 ways: innate resistance, where the cancer cells are naturally resistant from the beginning, or acquired resistance, where cancer cells become resistant after being exposed to the drug. Resistance can make the treatment less effective over time, so doctors often combine drugs to reduce the risk of resistance. Tumor growth is an important factor here. At the start, when a tumor is very small, it grows quickly, but as it gets bigger, the growth slows down. This is why smaller tumors, or those that are still in the early stages of spreading, micrometastases, are often more sensitive to chemotherapy. Larger tumors are harder to treat because they have fewer cells that are actively dividing, and chemotherapy drugs are most effective on dividing cells. To sum it up, chemotherapy uses drugs to kill cancer cells, but it also affects healthy cells. It's given in cycles to allow healthy cells to recover. The goal is to kill as many cancer cells as possible while managing side effects. Doctors need to adjust doses based on the patient's health and how the body processes a drug. Tumor size and the type of cancer can affect how well chemotherapy works. And that's the basics of chemotherapy. It's a powerful tool but needs careful management to balance effectiveness with the side effects. Radiotherapy uses high-energy radiation to treat cancer. The goal is to damage the DNA in cancer cells, preventing them from growing and dividing. This damage is caused by the creation of free radicals, which are unstable molecules that break apart and damage cellular structures like DNA. The radiation used can be in different forms: X-rays, electrons, protons, or even alpha particles. When the radiation hits the target tissue, it causes different types of reactions. The photoelectric effect occurs when the incoming photon, like X-ray, hits an electron in the tissue, transferring most of its energy to that electron. This energy causes the electron to ionize nearby molecules. The Compton effect is another common reaction in radiotherapy, where the photon hits an electron that isn't tightly bound, scattering both the photon and the electron. Finally, pair production happens at very high energy levels, where a photon interacts with an atom's nucleus, creating two electrons, one positive, one negative. The key idea here is that radiation needs oxygen in the tissue to be effective. Tumors with low oxygen levels, hypoxia, are harder to treat because the radiation relies on oxygen to produce the free radicals that damage DNA. Radiotherapy can be delivered in various ways, depending on the tumor's location and type. Electron beams are used for shallow tumors, like skin cancers, because they affect only the surface layers. Brachytherapy involves placing the radiation source directly inside or next to the tumor, often used for cancers in the prostate or cervix. Conformal radiation therapy shapes the radiation beam to fit the tumor, sparing surrounding healthy tissues. Intensity-modulated radiation therapy, IMRT, takes this a step further by adjusting the beam's intensity during treatment, providing a more precise dose to the tumor while minimizing damage to nearby healthy tissue. For tumors located close to critical structures, proton therapy might be used. Protons, unlike X-rays, deposit most of their energy at the end of their path, which minimizes the dose to surrounding tissues. This is especially useful for treating tumors near sensitive areas like the brain. Lastly, stereotactic radiosurgery delivers a high dose of radiation in a single session, using multiple beams to focus on small tumors, usually around 3 centimeters. It's a non-invasive technique commonly used for brain tumors and other difficult-to-reach areas. In short, radiotherapy works by using high-energy radiation to damage cancer cells, and there are many different ways to apply it depending on the tumor's location and size. Each method aims to maximize the effect on the cancer while minimizing harm to normal tissues. Radiotherapy and chemotherapy can have various side effects, and these are classified based on when they occur. Early effects happen during treatment or within the first few weeks after treatment ends. These effects are common and can be significant, but are often reversible. For example, chemotherapy can cause hair loss, alopecia, which usually starts a few weeks after treatment. Intermediate effects occur several weeks to months later, while late effects can happen many months or even years after treatment. These late effects can include things like memory problems in children who received radiation to the brain. One major concern during chemotherapy is extravasation injury, which occurs when a drug leaks out of the vein into surrounding tissue. If the drug is an irritant, it usually causes local inflammation and is not permanent. But if the drug is a vesicant, like anthracyclines or vinca alkaloids, it can cause severe tissue damage, and in some cases, the tissue may even need a skin graft. If extravasation is suspected, the force should be stopped immediately, and the area should be treated following local protocols. There are also specific toxicities associated with different types of cancer treatments. For example, cardiac toxicity can occur, leading to heart problems like arrhythmias or pericarditis. Gastrointestinal (GI) toxicity can include mouth sores, stomatitis, diarrhea, constipation, or even more severe conditions like enteritis or proctocolitis, depending on the drugs used. Liver damage can also happen with certain chemotherapy drugs, leading to conditions like cholestasis or liver necrosis. Neuropathy or nerve damage can result from drugs like cisplatin or vincristine, causing symptoms like numbness or tingling in the hands and feet. For pulmonary toxicity, certain chemotherapy drugs can cause lung damage, leading to conditions like fibrosis, while radiation can cause lung inflammation, pneumonitis. Reproductive system toxicity is another concern, especially for younger patients, as chemotherapy and radiation can affect fertility, leading to ovarian suppression or testicular dysfunction. Skin reactions are common too, especially after radiotherapy, leading to redness, peeling, and long-term skin changes. Teratogenesis, birth defects, is another risk, so patients should be advised to avoid pregnancy during and after treatment. Urothelial toxicity can cause bladder issues, like cystitis or bleeding, particularly with radiation or drugs like ifosfamide. Finally, one of the long-term risks of cancer treatment is the potential for secondary malignancies, meaning new cancers that develop as a result of the treatment. These are more common after chemoradiation and can include leukemia, soft tissue sarcomas, or bone cancers like osteosarcoma. It's important for medical professionals to monitor patients closely for these toxicities and provide supportive care as needed. Also, patients should be informed about these potential side effects before starting treatment, so they can make informed decisions and manage expectations. Nausea and vomiting are very common and distressing problems for cancer patients, especially those undergoing chemotherapy. These symptoms can lead to complications like dehydration, malnutrition, and electrolyte imbalances, which can delay or reduce the effectiveness of cancer treatment. Despite the improvements in treatment options, nausea and vomiting continue to be a major concern for many patients. The process of vomiting is controlled by the vomiting center in the brain, specifically in the fourth ventricle. This center receives signals from various parts of the body, such as the chemoreceptor trigger zone CTZ, hypothalamus, and vestibular system. Nausea, on the other hand, is an unpleasant sensation that happens when the stomach slows down and the small intestine starts to contract more. Various factors can trigger nausea and vomiting. These include chemical stimuli like chemotherapy drugs, visceral stimuli, such as irritation in the stomach, vestibular stimuli, for example, vertigo or motion sickness, sensory stimuli, such as bad smells, psychogenic causes, like anxiety or the anticipation of treatment. In cancer treatment, there are many causes of nausea and vomiting. Some are iatrogenic, caused by medical treatment, such as chemotherapy or radiation therapy. Others are due to metabolic disturbances like high calcium levels, hypercalcemia, or kidney failure. Tumors can also directly affect the digestive system, like when a tumor causes a blockage in the bowel or increases pressure in the brain. Emotional stress, like anxiety about treatment, can also make things worse. For treating nausea and vomiting, antiemetic drugs are commonly used. These work by blocking certain chemicals in the brain that trigger vomiting. There are several types of antiemetics, each working in a different way. Phenothiazines, e.g., prochlorperazine, block dopamine in the brain and are often used for mild nausea caused by chemotherapy or radiation. Antihistamines, e.g., promethazine, cyclizine, are used for motion sickness or nausea caused by vestibular issues like vertigo. Butyrophines, e.g., haloperidol, are helpful for nausea caused by opioids or other drugs affecting the CTZ. Serotonin antagonists, e.g., ondansetron, are especially effective for chemotherapy-induced nausea, particularly with highly emetogenic drugs like cisplatin. Metoclopramide is useful for both nausea and helping with gastric emptying, especially in chemotherapy cases. For patients with advanced cancer, chronic nausea is usually due to multiple factors. These patients may be on opioids or pain relief, which can cause constipation and worsen nausea. They may also suffer from dehydration or other metabolic imbalances. Managing this involves careful assessment and treatment, which often includes treating underlying causes like malignant bowel obstruction or hypercalcemia. Constipation should be treated aggressively with laxatives, and if patients can't take oral medications, alternatives like subcutaneous infusions may be needed. In summary, nausea and vomiting are complex symptoms in cancer care, and managing them effectively requires a multifaceted approach. The right antiemetic treatment can help improve patients' quality of life and allow them to continue their cancer treatment. Pain is one of the most challenging symptoms in cancer care. It's defined as an unpleasant sensory and emotional experience, often linked to actual or potential tissue damage. What makes pain particularly difficult is that it's highly subjective. Everyone experiences and reacts to pain differently, so pain management can vary from patient to patient. The concept of total pain is crucial here. It refers to the fact that pain in cancer patients isn't just physical. It involves emotional, psychological, and even spiritual factors, which all need to be considered in treatment. Many cancer patients experience significant pain during their illness. About 2/3 of cancer patients suffer from pain at some point. The pain can come from different places in the body and can be of various types. Understanding the source and type of pain is important for choosing the best treatment plan. Pain assessment is essential for effective management. Not all cancer-related pain is caused directly by the tumor. It could also stem from complications like weight loss, cachexia, infections, or pre-existing health problems. When assessing pain, it's vital to thoroughly understand the patient's concerns, expectations, and any social, emotional, or spiritual factors that could impact how they experience and deal with pain. Some pains can change over time, so regular reassessment is necessary. Cancer pain can be categorized into several types. Somatic pain. This is pain from tissue damage, like muscles or skin, and is usually sharp, localized, and described as aching or throbbing. It is transmitted through the spinal cord and can be pinpointed to a specific area. Neuropathic pain. This results from nerve damage, whether peripheral, outside the brain and spinal cord, or central, inside the brain or spinal cord. It's often described as burning, shooting, or tingling, like a sensation of pins and needles. Inflammatory pain. This type comes from inflammation in the body and is often caused by chemical signals like cytokines, small proteins involved in inflammation. These signals can make nerves more sensitive, causing pain. Visceral pain. This pain comes from internal organs like the stomach or liver. It's often vague, difficult to locate, and can be caused by things like organ distension, ischemia, lack of blood flow, or inflammation. Pain treatment follows the World Health Organization's WHO pain ladder, which guides doctors in selecting the right type of medication based on the severity of the pain. For mild pain, drugs like paracetamol or NSAIDs are used. For moderate pain, weak opioids such as codeine may be prescribed. Severe pain often requires stronger opioids like morphine, fentanyl, or oxycodone. It's important that opioids are given regularly rather than on an as-needed basis, and that patients are educated on how to use breakthrough doses when needed. In addition to medication, non-drug treatments can help manage pain. These include techniques like TENS, transcutaneous electrical nerve stimulation, acupuncture, and massage. Interventions like nerve blocks or spinal analgesia can be considered for more severe cases. Rehabilitative support, such as physiotherapy and behavioral therapies like relaxation training or hypnosis, can also be helpful. Opioids are the mainstay for managing moderate to severe cancer pain, but there are concerns about side effects such as constipation, nausea, and sedation. Over time, patients may become tolerant to some of these side effects. However, opioid use needs careful management to avoid serious issues like opioid toxicity, which can cause symptoms like confusion, respiratory depression, or hallucinations. It's essential to monitor patients carefully and adjust doses as necessary. In conclusion, managing cancer pain requires a comprehensive, ongoing approach. Effective pain control not only improves the patient's quality of life, but also supports them in continuing cancer treatment. Regular assessment and a combination of pharmacological and non-pharmacological interventions are key to successful pain management. When we conduct clinical trials, we're essentially running experiments to determine how effective a treatment is. These trials are carefully planned to give us objective, clear answers to specific questions. This is very different from just relying on plausible reasoning or assumptions about how a treatment might work. Clinical trials are done under controlled conditions to ensure the results are reliable, and they must follow strict guidelines to ensure the safety and well-being of the patients involved. There are different types of studies, and each has a different purpose. Observational studies are one example, where researchers simply observe and report on treatments and outcomes without controlling the treatments or procedures. These studies are useful for understanding patterns or causes of diseases, but they don't prove cause and effect relationships. Clinical trials, on the other hand, are more reliable for testing the effects of specific treatments. In Phase 1 clinical trials, the main goal is to figure out the highest dose of a new drug that can be given safely to patients. We also look at how the drug affects the body and any side effects it causes. These trials usually involve patients who have advanced cancer and who have no other treatment options left. We want to find the dose that is both safe and effective enough to be tested in later stages. Phase 2 trials move on to testing whether the drug works in specific types of cancer. At this stage, we might test the drug in a wider range of patients, but the goal is to see if it produces an actual effect, like shrinking tumors. The main endpoint here is the objective response rate, which is a percentage of patients who show improvement. However, just because a drug causes a tumor to shrink doesn't mean it will extend a patient's life. So Phase 2 trials alone don't give us a clear picture of long-term benefits. In Phase 3 clinical trials, we compare the new treatment to the standard one to see which works better. These are the most important trials for deciding on treatment guidelines, and they are often randomized, meaning patients are randomly assigned to one of the treatment groups. This helps reduce bias and makes sure the results are more reliable. Randomization helps ensure that each treatment group is similar and that the results aren't skewed by the patient's characteristics or how they were chosen for the trial. Lastly, meta-analysis comes in as a way to pool data from multiple clinical trials. It combines the results from several studies to get a clearer picture of how well a treatment works. But we need to be careful because not all trials are the same, and combining results from very different studies can sometimes lead to misleading conclusions. Meta-analyses are useful, but they don't replace the need for well-designed, large-scale clinical trials. Overall, clinical trials are crucial for testing new treatments, and understanding the different phases and methods of trial design helps us interpret the results accurately and make better decisions for patient care. In cancer care, a multidisciplinary team, MDT, plays a crucial role in providing comprehensive care. This team consists of various healthcare professionals who work together to make sure the patient receives the best possible treatment. The core members include doctors, nurses, and physiotherapists, but the team also includes other specialists, like occupational therapists, who help in specific areas during the patient's journey. The main purpose of the MDT is to ensure that every aspect of the patient's care is covered. The team meets regularly to discuss the patient's progress, treatment options, and to coordinate efforts across different specialties. This is especially important in cancer care, where the disease affects multiple systems in the body and requires a variety of expert inputs. The team comes together to make decisions on diagnostic tests, treatment plans, and any additional support the patient may need, such as psychological care, nutrition, or rehabilitation. One key responsibility of the MDT is to plan diagnostic and staging procedures to understand the extent of cancer. Based on this, they decide on the most suitable treatment approach, which might involve surgery, chemotherapy, or radiotherapy. They also ensure that patients are well informed about their treatment options, potential side effects, and any supportive care, like managing symptoms or stoma care. The benefits of MDTs are well documented. Studies show that having a multidisciplinary approach improves patient outcomes, like quality of life and survival rates, and also reduces costs. By working together early in the process, the team can provide treatment that aligns with current medical guidelines and meets the patient's needs more effectively. Additionally, working in an MDT leads to greater job satisfaction for healthcare professionals because they get to collaborate and support one another, improving communication and reducing redundancy in tests and treatments. One effective way that MDTs improve care is through combined clinics. In these clinics, multiple specialists are available during one visit, which means the patient can see all the necessary experts in one go. This avoids delays caused by waiting for referrals, and treatment decisions can be made quickly. MDT meetings are also an excellent opportunity to discuss clinical trials. When a patient's case is reviewed, the team can identify those who might be eligible for new treatments being tested. This is an important part of advancing cancer care, and having a research coordinator in the meeting can help ensure that potential candidates are not overlooked. For medical students and trainees, working with an MDT offers many educational benefits. You can see real-life examples of teamwork, learn about different treatment strategies, and get a chance to discuss complex cases. You also learn about decision-making ethical issues, and how research influences clinical practice. It's a great way to improve your knowledge of cancer and its management while gaining valuable experience in a collaborative healthcare setting. In summary, MDTs not only improve patient care but also provide valuable learning opportunities for students and healthcare professionals. The collaborative, patient-centered approach leads to better outcomes and ensures that patients receive the most comprehensive and timely treatment possible. When a cancer patient is nearing the end of their life, the main focus of treatment shifts from curing the disease to improving the quality of life. This is where palliative care comes in. It aims to relieve symptoms and provide emotional and social support for both the patient and their family. The care involves a multidisciplinary team, MDT, including doctors, nurses, and other specialists, working together to provide holistic care for the patient. There are many symptoms that can affect patients in the terminal stages of cancer, and controlling these symptoms is vital to improving the patient's comfort. One of the most common problems is constipation, often caused by medications like opioids, poor nutrition, or even bowel obstructions. Treatment usually involves laxatives and encouraging movement and hydration. Diarrhea can also be a concern, often caused by medications or treatments like chemotherapy. In this case, stopping the underlying cause and using medications like loperamide to control symptoms can help. Another common symptom is breathlessness, which may result from factors like lung tumors, pneumonia, or even anxiety. Treatment focuses on addressing the cause, if possible, and using oxygen or opioids to relieve symptoms. Cough can also be problematic, particularly in lung cancer. Treatments like cough syrups or opioid-based solutions can help calm the throat. Cachexia, the severe loss of muscle and fat tissue seen in many cancer patients, is another issue. It cannot be reversed by increasing food intake alone. Medications like corticosteroids may help stimulate the appetite, but the overall prognosis remains poor. Similarly, lymphedema, swelling caused by blockage in the lymphatic system, often occurs due to surgery, radiation, or tumor infiltration. Managing lymphedema with compression garments and skin care is important. In the mouth, cancer patients often face problems like dry mouth and mucositis, painful inflammation, which are commonly caused by treatments like chemotherapy or radiotherapy. Good oral hygiene and medications like Nistadin or fluconazole can help manage these issues. On the psychological side, many terminal cancer patients experience emotional distress, which can include depression and anxiety. Good communication is key, and involving the patient and their family in care decisions can help reduce anxiety. Treating physical symptoms can also improve a patient's mental state. If needed, antidepressants and additional psychological support should be provided. As death approaches, patients often need spiritual care to address their personal beliefs, fears, and hopes about dying. Families also need support in dealing with grief before and after the patient's death. A framework like the Liverpool Care Pathway (LCP) helps guide care in the final stages, ensuring that the focus remains on comfort. This may involve withdrawal of nutrition and hydration if it is clear that the patient is in the final hours of life. While this can be distressing for families, it typically does not cause discomfort for the patient. Overall, palliative care in the final stages of cancer focuses on providing comfort and dignity. It's not just about managing physical symptoms, but also addressing emotional, psychological, and spiritual needs, helping both the patient and their family navigate this difficult time. Cancer that originates from an unknown primary site is a unique and challenging situation. This condition is referred to as carcinoma of unknown primary, CUP, and it occurs when cancer spreads to other parts of the body before the primary tumor is detected. Sometimes, by the time doctors find the metastasis, they can't identify where the cancer started. This happens in about 5% of all cancer cases, making CUP the 7th most common cancer type. The symptoms of CUP usually stem from where the cancer has spread, such as the liver, bones, lungs, or lymph nodes. Some patients may present with nonspecific symptoms like weight loss, fatigue, or a general feeling of being unwell. Diagnosing CUP can be tricky. Despite extensive investigations, less than 20% of patients are diagnosed with a primary tumor before death. Often, even after autopsy, 70% of cases remain undiagnosed. Investigations and diagnosis. The first step in investigating CUP is to exclude other cancers that could be curable and to identify tumors that are more likely to respond to treatment. Doctors often start with a complete medical history, a physical exam, and basic blood tests to check for liver function, blood counts, and tumor markers. Imaging techniques like CT scans, MRI, and PET scans are also used to identify the spread of the cancer. However, testing needs to be carefully managed. Over-investigating can delay treatment, increase costs, and cause unnecessary stress for patients. Once possible primary sites are identified, an oncologist will determine the best course of action. Treatment options. Treatment for CUP is primarily palliative, meaning the goal is to relieve symptoms and improve the quality of life, not cure the cancer. For widely metastatic CUP, doctors typically use chemotherapy, which targets cancer cells throughout the body. Radiotherapy can also help treat specific sites of pain or discomfort, like bone metastasis. The response to chemotherapy in CUP patients varies. If the cancer is well-differentiated adenocarcinoma, a type of cancer that looks somewhat like normal tissue, the prognosis is usually poor, with most patients showing little response to chemotherapy. On the other hand, if the cancer might be from the ovaries or peritoneum, chemotherapy can sometimes produce excellent responses, with some patients achieving complete remission or prolonged disease-free survival. If a patient has a single site of metastasis, such as in the lungs or liver, surgery or radiotherapy may offer a longer period of disease-free survival. For men with bone metastasis, especially those showing signs of osteoblastic lesions, hormonal therapy, like that used for prostate cancer, might be an option. Prognosis. Unfortunately, CUP generally has a poor prognosis, with a median survival of 6 to 9 months. However, survival can be longer if the cancer has only spread to 1 or 2 sites, especially if it's not adenocarcinoma and doesn't involve the liver, bones, or adrenal glands. If the cancer involves the liver or adrenal glands, survival drops significantly to around 5 months. Factors that worsen the prognosis include adenocarcinoma histology, a type of cancer cell that is often more aggressive, multiple metastasis sites, involvement of liver, bone, or adrenal glands, supraclavicular lymph node involvement, nodes near the collarbone, male gender, poor performance status, the patient is too ill to carry out daily activities, significant weight loss, over 10% of body mass. Overall, CUP presents a difficult challenge due to its unpredictable nature and poor prognosis. Early recognition, careful investigations, and supportive care are crucial for managing these patients. Breast cancer is the most common cancer in women, following skin cancer, and it's also the leading cause of cancer death in women aged 35 to 54 in places like England. One of the challenges with breast cancer is that it can spread, metastasize, many years after the initial diagnosis, sometimes up to 20 years later. Despite this, early detection through screening and better treatments are improving survival rates, with 5-year survival rates increasing over time. Causes of breast cancer. Both genetic and hormonal factors play a role in the development of breast cancer. Around 10% of cases are linked to genetic factors, like mutations in the BRCA1 and BRCA2 genes. Hormonal factors are also important. For example, prolonged exposure to estrogen increases risk. Women who start their periods early, go through menopause late, or have children later in life, over 35 years old, are at higher risk. Nulliparity, not having children, is also a risk factor. Using the combined oral contraceptive pill does not seem to significantly increase breast cancer risk, but hormone replacement therapy, HRT, can increase the risk, especially with long-term use. Types of breast cancer. The most common type of breast cancer is invasive ductal carcinoma, which makes up about 70% of cases. Ductal carcinoma insitutsis is a non-invasive cancer that can be found through screening. Though it doesn't spread to lymph nodes at first if untreated, it can become invasive later on. Lobular carcinoma in situ, LCIS, is a condition that increases the risk of developing cancer in either breast. Symptoms of breast cancer. The most common way breast cancer is detected is through a lump that doesn't change with the menstrual cycle. Around 10% of patients may have a nipple discharge, but pain is not common. Only about 7% of patients experience it. Other less common symptoms include inflammatory carcinoma, which causes the skin of the breast to become swollen and red. Axillary lymph node involvement is another important sign, as it is the most significant predictor of how well a patient will do. Breast cancer can spread to various parts of the body, including the bones, lungs, liver, pleura, adrenals, skin, and even the brain. Treatment depends on the stage and type of cancer. Early-stage breast cancer can often be treated with wide local excision, removing the tumor, followed by radiotherapy to reduce the chance of the cancer returning. If the tumor is hormone receptor positive ER+, patients can also receive adjuvant hormonal therapy, like tamoxifen or aromatase inhibitors, to improve survival. For more aggressive cancers or larger tumors, chemotherapy may be recommended to reduce the risk of recurrence. Patients with HER2-positive breast cancer can benefit from a targeted treatment like trastuzumab, Herceptin, which targets the HER2 protein on cancer cells. For advanced breast cancer, treatments aim to control symptoms and prolong life. Radiotherapy can help with painful bone metastasis, and bisphosphonates may reduce complications related to bone metastasis. In patients with hormone receptor-negative tumors, chemotherapy may be necessary. Prevention and screening. One way to reduce the risk of breast cancer in high-risk women is chemoprevention with tamoxifen, which has been shown to lower breast cancer risk. However, not all studies have confirmed the same results. Breast cancer screening is another important preventive measure, and it's recommended for women at certain ages to catch cancers early, when treatment is most effective. Lung cancer is the most common cancer worldwide, and in the UK, it's the second most common, with around 41,000 new cases each year. Most of these cases are in people over 65, with the highest rates seen in those aged 80 to 84. Although smoking rates have decreased, lung cancer remains the leading cause of cancer death in both the UK and the USA. Risk factors. The biggest risk factor for lung cancer is smoking, which causes about 80 to 90% of cases. The more a person smokes, measured in pack years, the higher the risk. Even passive smoking, secondhand smoke, increases the risk. Other risks include previous radiotherapy to the chest, exposure to chemicals like asbestos, and a family history of lung cancer. Some rare genetic mutations, such as in the TP53 gene, can also contribute to the development of lung cancer. Types of lung cancer. There are two main types of lung cancer: small cell lung cancer, SCLC, and non-small cell lung cancer, NSCLC. Small cell lung cancer, SCLC, accounts for 20% of cases and is usually more aggressive. It often spreads quickly to other parts of the body, like the liver, bones, and brain. It is associated with neurosecretory granules that can produce hormones, leading to conditions like Cushing's syndrome or SIAD, syndrome of inappropriate antidiuretic hormone secretion. Non-small cell lung cancer, NSCLC, makes up about 80% of lung cancers and has three main types. Squamous cell carcinoma is the most common type and tends to grow slowly. It often causes infections and can be seen as a mass in the central airways. Adenocarcinoma is less linked to smoking and often appears in the outer parts of the lungs. It can metastasize and cause pleural effusions, fluid around the lungs. Large cell carcinoma is a more aggressive form that can present as a large mass and tends to spread quickly. Symptoms. Many patients with lung cancer have no symptoms at first, but common signs include a persistent cough, about 40% of patients, chest pain, coughing up blood, hemoptysis, and breathlessness, finger clubbing, especially in NSCLC. Other symptoms can include hoarseness due to involvement of the recurrent laryngeal nerve, difficulty swallowing, dysphagia, or shoulder pain. Lung cancer can also cause paraneoplastic syndromes, where the cancer produces abnormal hormones, leading to conditions like dermatomyositis or acanthosis nigricans. Diagnosis and staging. To diagnose lung cancer, doctors use a combination of chest X-rays, CT scans, and blood tests. A bronchoscopy is often done to get tissue for diagnosis. CT-guided biopsy or fine needle aspiration, FNA, may be used to confirm the diagnosis, especially if lymph nodes are involved. Peru time/central time scans are also becoming more common to determine whether surgery is an option. Treatment for lung cancer depends on the type and stage of cancer. Small cell lung cancer, SCLC surgery is usually not an option, so chemotherapy is the main treatment, often using etoposide combined with carboplatin or cisplatin. Radiation therapy can also be used for palliative care or to treat the brain to prevent metastasis. Non-small cell lung cancer, NSCLC, for early-stage cancer. Surgical removal of the tumor is often the best option, followed by chemotherapy. For more advanced stages, 3B or 4, surgery is not possible, and chemotherapy is used to control symptoms and slow disease progression. The treatment usually involves a combination of drugs like carboplatin or cisplatin with gemcitabine or vinorelbine. EGFR inhibitors, such as gefitinib or erlotinib, are used for patients with specific mutations in the EGFR gene. For more advanced stages, radiotherapy can be used both as a curative treatment or to help with symptoms like pain, breathlessness, and coughing. In cases of superior vena cava SVC obstruction, a stent may be inserted to help with blood flow, and radiotherapy can be used as a palliative measure. Paraneoplastic syndromes. Lung cancer can sometimes produce hormones that cause paraneoplastic syndromes. For example, ectopic production of ACTH can lead to Cushing's syndrome. Treating the lung cancer can often help reduce these symptoms, but if the symptoms return, it may indicate cancer relapse and further investigation is needed. In summary, lung cancer remains a major health issue worldwide. Understanding its causes, types, symptoms, and treatment options is crucial in managing and improving outcomes for patients. Mesothelioma is a rare and aggressive cancer that usually develops many years after exposure to asbestos, a material once widely used in construction and industry. It primarily affects the pleura, lining of the lungs, but can also involve the peritoneum, abdominal lining, and pericardium, heart lining. Risk factors and causes. Most mesothelioma cases appear around 60 years of age, often 20 to 50 years after someone's first exposure to asbestos. Men are 5 times more likely to get mesothelioma than women, and the risk increases with the amount and duration of exposure to asbestos. Interestingly, some people diagnosed with mesothelioma report exposure as children, often due to household or neighborhood exposure to asbestos. Even though awareness about asbestos and its risks has increased, the number of mesothelioma cases is expected to keep rising until around 2020 due to long latency periods. The primary cause of mesothelioma is exposure to asbestos fibers, which can cause DNA damage. Blue and brown asbestos, crocidolite, and amosite carry the highest risk, with white asbestos, chrysolite, being less dangerous. In some cases, a virus called SV40 is found in the cancer cells, suggesting it might play a role in developing the disease. Symptoms. The majority of mesothelioma patients will show symptoms that affect the lungs, such as cough, shortness of breath, and chest pain. Other signs include unexplained fever, weight loss, and fatigue. Sometimes, blood clotting disorders like thrombocytosis or disseminated intravascular coagulation can occur. Most patients present with a pleural effusion, fluid around the lung, that is visible on a chest X-ray, and fewer than 5% have bilateral involvement, both lungs. Mesothelioma can spread locally into nearby structures, like the chest wall or diaphragm, and it can even invade lymph nodes in up to 70% of cases. Diagnosis. On a chest X-ray, mesothelioma appears as a thick, irregular mass around the pleura. The tumor usually covers one side of the lung, with pleural plaques seen in some cases due to past asbestos exposure. CT scans help doctors assess how far the cancer has spread, with pleural thickening being a key finding. However, pleural effusions, fluid buildup, might be the only visible sign in some cases. To confirm mesothelioma, cytology, looking at cells and fluid from the pleura, is often not helpful, as it can be inaccurate. A biopsy is usually required, either via needle biopsy or a more invasive procedure like video-assisted thoracoscopy (VAT). The biopsy is crucial for diagnosis, but there's a risk that the cancer could spread along the needle track. Treatment: sadly, most patients are diagnosed at an advanced stage, where the cancer is not curable. However, treatments can help control symptoms and improve quality of life. Pain management, cough suppressants, and antibiotics for infections are important. Surgery is rarely an option unless the disease is localized. In some cases, decortication, removal of pleural tissue, or extrapleural pneumonectomy, removal of a lung and its lining, may be done. After surgery, radiotherapy is often used. For patients with advanced disease, chemotherapy, using drugs like carboplatin, cisplatin, and Pemetrexed can help manage symptoms, though it doesn't cure the cancer. Radiotherapy can also be used to shrink tumors or treat symptoms like pain or pleural effusion. Prognosis: mesothelioma has a poor prognosis, with a 5-year survival rate of only 5%. Most patients survive 6 to 18 months after diagnosis. In the UK, patients diagnosed with asbestos-related mesothelioma may be eligible for a lump sum payment to help with medical costs and benefits, and they should be referred for appropriate support. In summary, mesothelioma is a tough cancer to treat, mainly because it's diagnosed at later stages when it has already spread. Early diagnosis and managing symptoms are key to improving the patient's quality of life. Esophageal cancer is a serious condition that affects the tube connecting your mouth to your stomach. In the UK, about 4,000 people die each year from this cancer, making it the 9th most common cancer in adults. It's quite rare in people under 45, but the risk increases sharply with age, especially in those between 45 and 74. Men are much more likely to develop it than women, and it's significantly more common in countries like China than in the USA. Causes and types of esophageal cancer. There are 2 main types of esophageal cancer: adenocarcinoma. This is the most common type in the lower part of the esophagus, and it's often linked to gastroesophageal reflux disease (GERD), where stomach acid damages the esophagus. Obesity, hiatus hernia, and long-term use of medications like antacids are also risk factors. Squamous cell carcinoma. This type is more common in the upper and middle parts of the esophagus. It's linked to chronic irritation caused by things like alcohol, smoking, or conditions like achalasia, where the esophagus doesn't move food properly. In some cases, a condition called Plummer-Vinson syndrome, which causes iron deficiency anemia and difficulty swallowing, can increase the risk. In recent years, more people are being diagnosed with adenocarcinoma, which may be due to changes in diet, obesity, and smoking patterns. Symptoms. The most common symptom of esophageal cancer is dysphagia, or difficulty swallowing, especially solid foods. As the tumor grows, swallowing can become harder, and patients may also lose weight. Sometimes, people experience pain while swallowing or feel like food is getting stuck. Other symptoms include heartburn, shortness of breath, and iron deficiency anemia due to internal bleeding. In advanced stages, the cancer can spread to nearby areas, leading to complications like pneumonia due to an esophageal fistula, swelling of the lymph nodes, especially near the collarbone, liver enlargement, and pleural effusion, fluid in the lungs. In rare cases, the cancer can invade the aorta, causing heavy bleeding. Diagnosis and staging. Doctors usually confirm the diagnosis of esophageal cancer with upper GI endoscopy, where a tube with a camera is inserted into the esophagus to look for abnormalities. A biopsy, taking a tissue sample, is then done to confirm if it's cancer. Other tests, like CT scans and PET-CT, help determine how far the cancer has spread. In some cases, endoscopic ultrasound is used to check the depth of the tumor. Treatment for early-stage esophageal cancer. The best option is often surgery to remove the tumor, sometimes combined with chemotherapy or radiotherapy beforehand, called neoadjuvant therapy, to shrink the tumor. However, surgery is not an option for everyone, as many patients have other health problems. About 40% of patients are suitable for surgery, but the risks of surgery are significant, with complications like leakage, strictures, and reflux. For those with more advanced disease, chemoradiation, a combination of chemotherapy and radiation, may be used. Stent placement can help relieve swallowing difficulties. In cases of metastasis, treatment is usually palliative, focusing on symptom relief, which could include more chemotherapy or radiotherapy. Prognosis. The survival rate for esophageal cancer heavily depends on how advanced it is at the time of diagnosis. If caught early, the 5-year survival rate can be over 90%, but it drops significantly as the cancer spreads. If the cancer is localized, confined to the esophagus, the survival rate is around 30 to 80%. Once it spreads to lymph nodes or distant organs, survival chances drop to less than 2%. Overall, the 5-year survival rate in the UK is just 8%. Prevention and surveillance. The good news is that prevention is possible. Half of esophageal cancers could be avoided by educating people about the dangers of smoking, drinking too much alcohol, and eating a healthy diet, lots of fruits and vegetables, fewer processed foods. For those with Barrett's esophagus, a condition where the lining of the esophagus changes due to long-term acid reflux, regular endoscopic surveillance is recommended. If dysplasia, abnormal cell growth, is found, treatment options like proton pump inhibitors or even surgery may be needed. In summary, esophageal cancer is a challenging disease, often diagnosed late. Early detection, lifestyle changes, and careful management of risk factors can help reduce its impact. Gastric cancer or stomach cancer is the 6th most common cancer in the UK, making up about 5% of all cancers. Worldwide, it's the 2nd most common type of cancer. Most cases are diagnosed in people over 55 years old, with an average age of 65. The risk is higher in men, with a male-to-female ratio of about 1.8 to 1. Interestingly, the incidence of gastric cancer is decreasing in developed countries, likely due to better food preservation and diet changes. However, it is still a major issue in countries like China, where 40% of all cases occur. Causes of gastric cancer. The causes of gastric cancer are closely related to dietary factors. Nitrosamines, found in preserved meats and a diet high in salty foods, such as in Japan, are significant risk factors. Another big cause is Helicobacter pylori, a bacteria linked to atrophic gastritis, a condition where the stomach lining becomes thin, which increases the risk of developing gastric cancer. Chronic inflammation caused by this bacteria can lead to a decrease in stomach acid, allowing harmful bacteria to grow, which in turn increases the production of nitrates, a known cancer risk factor. Family history and certain genetic mutations, such as those in the cadherin-1 gene, CDH1, also increase the risk. In some cases, surgery like vagotomy, cutting part of the vagus nerve, or partial gastrectomy can increase the risk of cancer later on. Other factors like obesity, radiation exposure, and a lower socioeconomic status can also contribute to the risk. Pathophysiology. More than 95% of gastric cancers are adenocarcinomas, which are cancers that develop from the glandular cells lining the stomach. These can be further divided into intestinal adenocarcinoma, which has a better prognosis and usually occurs in the distal stomach, and diffuse adenocarcinoma, which is more common and generally has a worse outcome. Rare forms of gastric cancer include squamous cell carcinoma, lymphomas, and gastrointestinal stromal tumors, GIST. Symptoms. In the early stages, gastric cancer may have no symptoms or very mild ones, like indigestion, feeling tired, or not wanting to eat. As the disease progresses, Patients often experience epigastric pain, pain in the upper stomach area, early fullness after eating, weight loss, and nausea. Advanced disease can lead to more severe symptoms like ascites, fluid buildup in the abdomen, jaundice, yellowing of the skin, liver enlargement, and swollen lymph nodes, like the varicose node near the collarbone. If the cancer spreads to the ovaries, it can form a Krukenberg tumor, which is rare but serious. Diagnosis and staging. Patients over 55 years old with symptoms like indigestion, dyspepsia, or weight loss should be referred for an urgent endoscopy. A biopsy during endoscopy is essential for confirming cancer. Blood tests may show iron deficiency anemia due to blood loss, and liver function tests may be abnormal if the cancer has spread to the liver. Imaging tests like CT scans, ultrasound, and X-rays can help detect metastasis and spread to nearby organs. Treatment. For early-stage gastric cancer, surgery is the most effective treatment with laparotomy, surgical opening of the abdomen, and sometimes laparoscopy for staging. However, not all patients are candidates for surgery, and only about 50% can undergo curative surgery. For antral cancers, cancer in the lower part of the stomach, a subtotal gastrectomy is preferred, while total gastrectomy may be required for mid-gastric tumors. In some cases, endoscopic mucosal resection, a minimally invasive procedure, can be used for early-stage cancers. Chemotherapy and radiotherapy are often used in combination with surgery, but their benefits are limited, especially in preventing relapse. For advanced gastric cancer, chemotherapy regimens like fluoropyrimidines are commonly used, though they offer only modest survival benefits. Targeted treatments, such as trastuzumab for HER2-positive cancers, are increasingly used, especially for patients with gastroesophageal junction adenocarcinomas. Prognosis. Unfortunately, gastric cancer is often diagnosed at a late stage, which greatly reduces the chances of survival. In the UK, around 50% of patients present with advanced disease, leading to a 5-year survival rate of just 15%. However, younger patients under 50 have a slightly better chance, with survival rates ranging from 16 to 22%. For advanced metastatic disease, the survival rate is very low, and the median survival is around 6 months. In summary, gastric cancer remains a significant health challenge, especially in countries like China and Japan, where diet and infection play a major role. Early detection through endoscopy and improving lifestyle factors, such as diet and avoiding smoking, can help reduce the burden of this disease. Colorectal cancer is the third most common cancer in the UK and the second leading cause of cancer deaths. It mostly affects people over 60 years old, with 85% of cases occurring in this age group. Interestingly, the incidence is much higher in developed countries, especially in places like New Zealand, Canada, the USA, and the UK. This cancer affects both genders equally, so there's no significant gender bias. Causes of colorectal cancer. The main cause of colorectal cancer is lifestyle factors. Diet plays a huge role, especially eating too much red meat, alcohol, and a high-calorie diet. Smoking, a sedentary lifestyle, and obesity also increase the risk. Additionally, people with inflammatory bowel disease, IBD, like Crohn's disease or ulcerative colitis, are at a higher risk, especially if they've had the disease for a long time. In about 5% of cases, colorectal cancer is due to genetic syndromes. The most common one is Lynch syndrome, or hereditary non-polyposis colorectal cancer, HNPCC, which is caused by mutations in genes responsible for fixing DNA errors. People with this condition have a 40% chance of developing colorectal cancer, usually in their 40s. They can also develop other cancers, like ovarian, endometrial, and gastric cancers. Another rare genetic disorder is familial adenomatous polyposis, FAP, where patients develop numerous benign polyps in their colon from a young age. If untreated, these can turn into cancer, so prophylactic colectomy, removal of the colon, is often recommended. How colorectal cancer develops. Most colorectal cancers are adenocarcinomas, which develop from benign adenomatous polyps in the colon. These polyps are usually slow-growing, but over time, some may transform into cancer, especially if they are large or have been present for a long time. Once the cancer develops, it can spread to the layers of the bowel wall and to other parts of the body, like the liver, lungs, bones, and brain. Symptoms. In the early stages, colorectal cancer often has no symptoms, so about 55% of patients are diagnosed with advanced disease. People with right-sided colon cancer might have a palpable mass in the right side of the abdomen, diarrhea, weight loss, anemia, and hidden blood in the stool. Those with left-sided colon cancer often experience a palpable mass on the left side, a change in bowel habits, usually constipation, rectal bleeding, and signs of bowel obstruction. Left-sided cancers are usually diagnosed earlier than right-sided ones. Diagnosis and staging. If colorectal cancer is suspected, doctors will do a rectal exam, check the full blood count, and test the liver and kidney function. Colonoscopy is the most important test, where doctors examine the colon and take biopsies. If a patient can't have a colonoscopy, a sigmoidoscopy or barium enema might be used instead. CT scans of the chest, abdomen, and pelvis help determine how far the cancer has spread. The TNM staging system and Duke staging are used to assess how advanced the cancer is. Treatment. The main treatment for colorectal cancer is surgery to remove the tumor and nearby lymph nodes. About 80% of tumors are resectable. For rectal cancer, surgery is more difficult, but total mesorectal excision has improved survival rates. Chemotherapy, often with drugs like 5-fluorouracil and irinotecan, can help reduce the chance of relapse, especially after surgery. Biological therapies like bevacizumab, which targets blood vessel growth, and cetuximab, which blocks cancer cell signals, have improved outcomes for advanced cancer. Prognosis. The prognosis depends on how early the cancer is detected. For example, the 5-year survival rate for Duke Stage A, tumor confined to the mucosa, is about 93%, but for Stage D, when the cancer has spread to distant organs, it's only 7%. Screening. Screening for colorectal cancer is important, especially for people over 50 years old. Studies have shown that screening for hidden blood in stool can reduce deaths from colorectal cancer. In the UK, there's a pilot program for screening, and it's estimated that this could reduce mortality by up to 16%. People at high risk, such as those with Lynch syndrome or FAP, need regular colonoscopy surveillance to catch any problems early. In conclusion, colorectal cancer is a significant health issue, especially in developed countries. It's mostly caused by lifestyle factors, but genetic conditions can also play a role. Early detection through screening and lifestyle changes, such as improving diet and exercise, can help reduce the burden of this disease. Pancreatic cancer is the 10th most common cancer in the UK, with around 7,600 new diagnoses every year. It's also the 5th leading cause of cancer deaths. People are usually diagnosed between the ages of 60 to 65, though about 40% of cases occur in people under 75. Interestingly, men are more likely to get it before 75, but after that, women are at a slightly higher risk. Causes of pancreatic cancer. The main risk factor for pancreatic cancer is smoking, which increases the risk by 5 times. The links between alcohol and coffee consumption and pancreatic cancer are not very clear and vary between studies. Some researchers have also looked into diabetes and chronic pancreatitis as potential risk factors. But since these conditions can also develop as a result of pancreatic cancer, the evidence is not very strong. About 90% of pancreatic cancers are adenocarcinomas that come from the ductal cells, which line the pancreatic ducts. The remaining 5% are endocrine tumors that arise from the pancreas's islet cells, and another 5% are from acinar cells. Symptoms. Most pancreatic cancers develop in the head of the pancreas, which causes symptoms like epigastric pain, weight loss, and jaundice, yellowing of the skin. Tumors in the body or tail of the pancreas tend to cause pain in the left upper abdomen and can even cause constipation if they affect the colon. The pain often becomes more severe over time and can radiate to the back as the cancer spreads. Occasionally, pancreatic cancers are located near the ampulla fata, where the bile duct meets the duodenum, and cause early jaundice, which might help with earlier diagnosis. When the cancer spreads, it commonly goes to the liver and lungs, and the disease can also affect the lymph nodes, particularly near the portal vein and aorta. Some patients may have diabetes as the first sign of pancreatic cancer, which can appear months before other symptoms. Other signs include migratory thrombophlebitis, Trousseau's sign, fever from cholangitis and ascites, fluid in the abdomen. Diagnosis. Early pancreatic cancer is hard to diagnose, especially since many patients don't show symptoms until the cancer has advanced. If a patient has ongoing upper abdominal pain, pancreatic cancer should always be considered. Some of the tests used for diagnosis include endoluminal ultrasound, which provides clearer images than regular abdominal ultrasound, CT scans, which can show a mass or signs of cancer spread, endoscopic retrograde cholangiopancreatography, ERCP, a procedure where a scope is passed into the bile ducts, allowing doctors to collect tissue samples or even insert a stent if there's a blockage. Blood tests can check liver function, renal function, and the CA19-9 tumor marker, which may be elevated in pancreatic cancer. Treatment. Unfortunately, surgical resection is only an option for about 20% of patients, as pancreatic cancer is often diagnosed too late. Surgical options like pancreaticoduodenectomy, Whipple procedure, and total pancreatectomy are complex surgeries with high risks, including the potential development of diabetes and loss of pancreatic function, requiring insulin and digestive enzymes. For patients who can undergo surgery, palliative care focuses on relieving symptoms. This might include endoscopic stenting to treat jaundice, gastric bypass for duodenal obstruction, or a nerve block for pain. Chemotherapy with drugs like gemcitabine can help control the disease and improve symptoms, but pancreatic cancer is resistant to many treatments. Another chemotherapy combination, FOLFIRINOX, which includes 5-fluorouracil, irinotecan, oxaliplatin, and folinic acid, has been shown to improve survival, but it's more toxic than gemcitabine alone. Prognosis. Pancreatic cancer is known for its poor prognosis. The 1-year survival rate is about 16%, and the 5-year survival rate is very low, around 3%. However, if the cancer is diagnosed early, especially if it's located in the periampullary region, the survival rate can be better, with some patients surviving up to 5 years. In patients with locally advanced or metastatic disease, survival is usually very short, with a median survival of 3 to 4 months. But improvements in palliative care have helped increase short-term survival and comfort for patients with advanced disease. In summary, pancreatic cancer is a challenging condition with a high mortality rate. It's often diagnosed too late for surgery, and treatment options are limited. Early detection, especially for those at high risk, remains critical for improving survival outcomes. Hepatocellular carcinoma, HCC, is one of the most common liver cancers worldwide. While it's not as common in the UK, with about 2,800 cases per year, it still represents a significant portion of liver cancers. HCC is particularly widespread in regions like East Asia and Sub-Saharan Africa, where chronic hepatitis B virus, HBV, infection is more common. It tends to be more frequent in men, and most people are diagnosed in their 5th or 6th decade of life as liver cirrhosis, which increases the risk of HCC. Takes time to develop. Causes of HCC. The primary cause of HCC is chronic hepatitis B and hepatitis C, HCV infections. In fact, over 70% of HCC cases worldwide are linked to these viral infections. For people with HBV, the lifetime risk of developing HCC is about 40%, and it's even higher with HCV. Other risk factors include alcoholic cirrhosis, aflatoxin exposure, a toxin produced by fungi on crops, primary biliary cirrhosis, and inherited metabolic disorders like hemochromatosis, iron buildup, and tyrosinemia, amino acid buildup. For cholangiocarcinoma, a cancer of the bile ducts, primary sclerosing cholangitis increases the risk significantly, with a 10 to 20% lifetime risk of developing the disease. Liver fluke infections are also linked to a higher incidence of cholangiocarcinoma, especially in Southeast Asia. Symptoms. In the early stages, HCC often doesn't cause noticeable symptoms, or it may cause vague symptoms like weight loss, nausea, and fatigue. Sometimes there can be pain in the right upper abdomen as the liver stretches. If the tumor blocks a bile duct, jaundice, yellowing of the skin and eyes may develop, signaling a more advanced stage. Later on, symptoms can include liver failure, acute abdominal pain, and distension due to hemorrhage in the abdomen, which can be life-threatening. Cholangiocarcinoma, on the other hand, tends to present with jaundice, itching, pruritus, and hepatomegaly in large liver. As the disease progresses, patients may experience right upper quadrant pain, weight loss, and a palpable gallbladder, known as Courvoisier's sign. Diagnosis. To diagnose HCC, doctors will first do some routine blood tests, including liver and renal function tests. Ultrasound is often used to visualize the liver, and if a lesion is found, it may indicate HCC, especially in someone with cirrhosis. The blood test for alpha-fetoprotein AFP is elevated in about 75% of HCC cases, so it's a helpful marker for diagnosis. CT scans and MRI with contrast are then used to assess the tumor's extent and decide on treatment options. For cholangiocarcinoma, liver function tests will typically show high levels of bilirubin, a substance related to bile flow, and markers like CEA and CA19-9 may also be elevated. MRCP, magnetic resonance cholangiopancreatography, is used to visualize the biliary tree and locate blockages. Treatment. Surgery is the best chance for curing HCC, but it's only possible for a small number of patients, particularly those without cirrhosis. In a healthy liver, up to 80% of the liver can be safely removed, but in cirrhotic livers, even small resections can lead to liver failure. For cirrhotic patients, a liver transplant is the preferred treatment, especially if the tumor is small, less than 3 centimeters. If surgery isn't an option, other treatments like sclerotherapy, injecting chemicals into the liver, or hepatic embolization, blocking the blood supply to the tumor, may be used. Radiofrequency ablation can destroy superficial tumors by using heat. Chemotherapy is generally not very effective for HCC, but some drugs like gemcitabine and mitoxantrone can be used to manage advanced cases. A newer treatment, sorafenib, is a drug that blocks tumor growth and blood supply, improving survival by a few months. For cholangiocarcinoma, if detected early, surgery to remove the tumor can help. In more advanced cases, surgery may still be possible, or a procedure like the Whipple procedure, removal of parts of the stomach, duodenum, pancreas, and gallbladder, may be done. Stents can also be placed to relieve bile duct blockages. Gemcitabine and cisplatin chemotherapy are effective for cholangiocarcinoma. Prognosis. The prognosis for liver cancer depends largely on whether the tumor can be surgically removed. For patients who undergo liver resection, the 5-year survival rate is about 30%. If the patient gets a liver transplant, the survival rate can go up to 75%. However, if surgery isn't an option, the survival rate drops dramatically, with patients living around 6 to 7 months after diagnosis. For cholangiocarcinoma, the 5-year survival rate is very low, about 5%. Intrahepatic cholangiocarcinoma has the worst prognosis, with a median survival of just 12 to 18 months after diagnosis. One of the best ways to prevent HCC is through vaccination against hepatitis B, especially in regions where HBV is common. Early detection and treatment of underlying liver conditions can also significantly improve outcomes. Ovarian cancer is the 4th most common cancer in the UK and leads to about 5% of all cancer deaths in women aged 40 to 60 years. The average age when ovarian cancer is diagnosed is around 60 years. It's important to note that cancers of the fallopian tube and peritoneum the lining of the abdomen, can look similar to ovarian cancer, and they are often treated the same way. Causes and risk factors. Certain factors seem to protect against ovarian cancer. Pregnancy, prolonged breastfeeding, and taking the oral contraceptive pill, especially those high in estrogen, can reduce the risk. Family history also plays a role. Up to 7% of women with ovarian cancer have a family history of the disease. There are two main genetic patterns linked to ovarian cancer: BRCA1 and BRCA2 mutations. These are linked to hereditary breast and ovarian cancer, increasing the risk of both cancers. Lynch syndrome, type 2, this genetic condition increases the risk of several cancers, including ovarian, colorectal, and endometrial cancer. Types of ovarian cancer. The most common type of ovarian cancer is epithelial carcinoma, which accounts for about 90% of cases. This can appear in several forms. Serous adenocarcinoma, most common type. Mucinous adenocarcinoma. Endometrioid adenocarcinoma. Clear cell carcinoma. Other rarer types of ovarian tumors include germ cell tumors, carcinosarcomas, aggressive cancers, and sex cord tumors, which can produce hormones leading to symptoms like virilization or abnormal bleeding. Symptoms. Ovarian cancer is often asymptomatic in the early stages, which makes it difficult to detect. By the time symptoms appear, the cancer is often advanced. Common symptoms include abdominal bloating, nausea and vomiting, back pain, weight loss, changes in bowel habits, sometimes pleural effusion, fluid in the lungs, ascites, fluid in the abdomen, or bowel obstruction may occur in more advanced stages. If the cancer has spread to the abdomen, Sister Mary Joseph nodules, a sign of advanced disease, may appear around the belly button. Diagnosis. To diagnose ovarian cancer, doctors use transvaginal ultrasound, serum CA-125, a blood test, and the patient's age to distinguish ovarian cancer from benign cysts. These tests have a high level of accuracy, 80 to 90%. If cancer is suspected, CT scans may be used to check for spread to other organs like the liver, lungs, or lymph nodes. Surgery is often needed to confirm the stage of the cancer and assess its spread using the FIGO staging system. Treatment. Surgery is the main treatment, and the goal is to remove as much of the tumor as possible. This often involves removing the ovaries, fallopian tubes, uterus, and surrounding tissue. After surgery, most women will need chemotherapy, usually with carboplatin and paclitaxel. For women with high-risk disease, bevacizumab, a drug that blocks blood vessels feeding the tumor, may be added. For women with extensive disease at diagnosis, neoadjuvant chemotherapy, given before surgery, may be used to shrink the tumor, making surgery easier. In cases of relapse, second-line chemotherapy may be used, with a response rate of 20 to 40%. Complications. In advanced ovarian cancer, the disease can spread, causing complications like ascites, fluid buildup in the abdomen, bowel obstruction, hydronephrosis, kidney damage due to blocked urine flow. Patients are also at high risk of developing blood clots, deep vein thrombosis, or pulmonary embolism, which is linked to the cancer's activity. Even with blood thinners, clots can still form. Prognosis. The prognosis for ovarian cancer depends on the stage at diagnosis. The 5-year survival rate is about 30%, but it ranges from over 90% for stage 1 to less than 25% for stage 4. If the cancer is resistant to platinum-based chemotherapy, the survival rate is lower. However, women with BRCA mutations may have a better response to platinum chemotherapy and longer survival. The best outcomes occur when the cancer can be completely removed during surgery, known as cytoreduction. Women who achieve complete cytoreduction tend to have the longest survival and the best treatment responses. In conclusion, ovarian cancer is challenging due to its silent early stages, but with early detection, surgery, and chemotherapy, many women can achieve remission. Endometrial cancer is the 5th most common cancer in women in the UK and mostly affects postmenopausal women, especially those aged 60 to 79 years. It's the most common type of uterine cancer, with most cases being adenocarcinomas. There are 3 types of adenocarcinoma: endometrioid, the most common, papillary serous, and clear cell, which are rare. Carcinosarcoma, a more aggressive form, is much less common. Causes and risk factors. A major cause of endometrial cancer is high levels of estrogen without enough progestogen to balance it. Conditions that lead to high estrogen levels or low progestogen levels, such as obesity, diabetes, and hypertension, can increase the risk. Other risk factors include having Lynch syndrome, which is linked to several cancers, or endometrial hyperplasia, a condition where the lining of the uterus grows too thick. However, factors like having children and using the combined oral contraceptive pill can protect against endometrial cancer. Symptoms. The early sign of endometrial cancer is postmenopausal bleeding, PMB, meaning any bleeding after menopause. Other symptoms may include abnormal bleeding between periods or heavier than usual periods, menorrhagia. Women with this kind of bleeding should be investigated, especially those over 45. Less common symptoms include abdominal discomfort, vaginal discharge, and pain during sex. In advanced stages, patients may experience urinary problems, fatigue, loss of appetite, back pain, or constipation. Endometrial cancer usually spreads locally through the uterus, cervix, and vagina. It can also spread through the lymphatic system, though blood spread, hematogenous spread, happens later in the disease, so widespread metastasis at diagnosis is uncommon. Diagnosis. The first step in diagnosing endometrial cancer is a transvaginal ultrasound, which checks the thickness of the endometrium, the lining of the uterus. If the endometrial thickness is greater than 4 millimeters in postmenopausal women, it might suggest cancer. To confirm the diagnosis, an endometrial biopsy is done. This can be done using a PIPL, hysteroscopy, or dilatation and curettage DNC. However, a PIPL biopsy can't check if the cancer is spread to the deeper layers of the uterus. A blood test for CA-125 can be done, but it's not very reliable for endometrial cancer. It's more useful for monitoring the disease once it's diagnosed. If cancer is suspected, CT scans and pelvic MRIs are used to check for the spread of the cancer. Staging of the cancer is done using the FIGO staging system, which is based on surgical findings. Treatment depends on the stage and grade of the cancer. For early stage cancer, stage 1A, surgery is usually enough. This involves removing the uterus, total hysterectomy, and ovaries by lateral salpingo-oophorectomy. For stage 1B or stage 2 cancer, or higher grade cancers, radiotherapy is given to reduce the chance of recurrence. In women who can't have surgery or have advanced disease, stage 3 or 4, radiotherapy may be used as the main treatment. For recurrent cancer, hormonal therapy with progestogens can slow the growth of the tumor. However, it's most effective in well-differentiated cancers that express progesterone receptors. If the cancer is more aggressive, chemotherapy, like carboplatin and paclitaxel, can be used, though it doesn't usually improve survival much. Combining hormonal therapy with chemotherapy doesn't seem to provide additional benefits. Complications. Treatment, particularly pelvic radiotherapy, can cause both short and long-term side effects. Short-term effects include nausea, tiredness, diarrhea, and urinary issues like cystitis. Long-term problems may include early menopause, vaginal dryness, bladder issues, and ongoing diarrhea. Progestogen therapy can also cause side effects like water retention, breast tenderness, and nausea. Prognosis. Endometrial cancer has one of the best prognoses among gynecological cancers, especially if detected early. Factors that worsen the prognosis include older age, advanced stage, high-grade tumors, and adenosquamous histology, a mixed cancer type. Recurrent cancer often occurs at the vaginal vault, the top part of the vagina, and tends to show up within 2 to 3 years of the initial treatment. In summary, endometrial cancer is usually diagnosed early due to symptoms like abnormal bleeding. With early treatment, especially surgery, the chances of recovery are high. However, in advanced stages, treatment can be more challenging. Cervical cancer is the seventh most common cancer among women in the UK, accounting for about 2.5% of all cancer cases. Worldwide, it's more prevalent, especially in developing countries, where around 80% of cases occur. The average age of diagnosis is between 35 and 44 years. Thanks to screening programs, the rates of cervical cancer have dropped significantly over time, with the cervical smear test playing a key role. Causes and risk factors. Cervical cancer usually develops from an infection with human papillomavirus, HPV, which leads to cervical intraepithelial neoplasia, CIN, a condition where the cells on the cervix start changing abnormally. CIN can progress through 3 stages. CIN 1 affects the lower third of the cervix. CIN 2 involves the lower 2/3. CIN 3 involves the full thickness of the cervical epithelium. When CIN progresses and invades deeper tissues, it becomes invasive cervical cancer. The main HPV types that cause cancer are HPV-16 and HPV-18. Other risk factors include having multiple sexual partners, early sexual activity, smoking, using oral contraceptives for long periods, low socioeconomic status, and being immunocompromised, like in HIV. HPV vaccination, e.g., Cervarix and Gardasil, can prevent many cases of cervical cancer by protecting against the high-risk strains. Symptoms. In the early stages, CIN and microinvasive disease are usually asymptomatic. As the cancer progresses, patients might experience postcoital bleeding, bleeding after sex, intermenstrual bleeding, bleeding between periods, or postmenopausal bleeding. Vaginal discharge may also become offensive in odor. Pain is not a common early symptom but may develop as the disease advances. Advanced cancer can lead to symptoms like urinary problems, rectal bleeding, back pain, and pain in the legs due to the spread to nearby organs like the bladder or rectum. Diagnosis and staging. Colposcopy is the main diagnostic test, where a special solution, acetic acid, is applied to the cervix and abnormal areas are visually examined for features like leukoplakia, white patches, or mosaic patterns. A biopsy is then taken to confirm the diagnosis. If the disease has spread, further tests like CT, MRI, or cystoscopy, bladder examination, may be needed. Cervical cancer is staged using the FIGO system, which helps to understand the extent of the disease, but it doesn't include lymph node involvement. Screening. In the UK, women aged 25 to 49 years receive a cervical smear every 3 years, and women aged 50 to 64 years every 5 years. This helps detect abnormal cells before they become cancerous. If abnormal cells are found, further tests and treatments can prevent invasive cancer. After treatment for abnormal cells, follow-up screening is crucial to check for any recurrence. Treatment. The treatment approach depends on the stage of the cancer, the woman's age, health, and whether she wants to preserve fertility. For CIN 2/3, treatment might involve loop diathermy, a procedure to remove abnormal tissue, or a loop biopsy. For early stage, stage 1 cancer, treatment can involve hysterectomy, removal of the uterus. Stage 1B and 2 cancers are treated with either radical hysterectomy, removal of the uterus, cervix, and surrounding tissue, or pelvic radiotherapy. For more advanced stages, stage 2B and 3, treatment involves pelvic radiotherapy and chemoradiotherapy, chemotherapy combined with radiation. Stage 4 or recurrent cervical cancer is treated with chemotherapy. Prognosis. The prognosis for cervical cancer depends on the stage and type of cancer. The presence of adenocarcinoma, a type of cancer originating in glandular tissue, generally indicates a poorer prognosis. Lymph node involvement, a large tumor, or early recurrence also worsen the outlook. However, if there is no recurrence after 5 years, the patient is likely cured. In summary, cervical cancer can often be prevented or treated effectively if detected early through regular screening. It's important to consider HPV vaccination and early detection for better outcomes. Germ cell tumors, GCTs, are rare cancers, but are the most common type of testicular cancer in men, and they also occur in women, though less frequently. These tumors make up about 95% of testicular cancers and 3 to 5% of ovarian cancers. GCTs mainly affect young men aged 20 to 40 years and young women and adolescent girls. One of the key things about GCTs is that most patients can be cured, which is positive news for those diagnosed. Risk factors. Some factors increase the likelihood of developing GCTs, including Klinefelter syndrome, a condition where males have an extra X chromosome, previous testicular cancer, and conditions like infertility or atrophic testis, small, underdeveloped testicles. In utero exposure to estrogens is another possible risk factor. A family history of testicular cancer is also a significant risk, although there is no clear genetic link identified yet. Types of GCTs. There are two main types of GCTs. Seminomas. These are the most common in men, especially between the ages of 30 and 40. In women, a similar tumor is called a dysgerminoma, and it occurs mostly in young women. These cancers tend to grow slowly and can take years to show symptoms. Non-seminomas. These tend to spread faster than seminomas and are often diagnosed at later stages. Tumor markers like AFP, alpha-fetoprotein, and HCG, human chorionic gonadotropin, are usually elevated in these cases, helping with diagnosis. Clinical presentation. Testicular GCTs often present as a painless lump in the scrotum, and the testicle may become enlarged. Other symptoms can include scrotal pain, back pain, or a dragging sensation in the scrotum. In some cases, gynecomastia, breast tissue enlargement, occurs due to increased HCG levels. It's important to distinguish these from conditions like epididymal orchitis, which causes similar symptoms, but would typically improve with antibiotics. Ovarian GCTs, on the other hand, often grow rapidly, and symptoms can develop quickly within a few weeks. These include abdominal pain, palpable masses, and sometimes ascites, fluid in the abdomen, which can be due to infection or rupture of the tumor. Vaginal bleeding is less common but can occur, especially if the tumor causes other issues like bowel or urinary obstruction. Diagnosis and staging. To diagnose GCTs, serum tumor markers are key. AFP, HCG, and LDH, lactate dehydrogenase, are measured, and their levels can help determine the type of tumor and its prognosis. CT scans of the chest, abdomen, and pelvis are done to check the extent of the disease. Staging helps determine how far the cancer has spread. The International Germ Cell Consensus Classification helps predict outcomes based on these factors. In ovarian GCTs, especially in younger women, measuring AFP, HCG, and LDH is crucial. Treatment. For testicular GCTs, the first step is usually radical inguinal orchidectomy, surgical removal of the affected testicle. After surgery, tumor markers are monitored, and if levels don't drop as expected, there might be residual disease. For seminomas, radiotherapy or a single dose of carboplatin can reduce the risk of the cancer coming back. Non-seminomas are treated with chemotherapy, often using the BEP regimen, bleomycin, etoposide, and cisplatin, which has been shown to reduce relapse. For ovarian GCTs, surgery is the main treatment, with an effort to preserve fertility whenever possible. Chemotherapy with BEP is often given after surgery, especially if the tumor is advanced or if there is residual disease. Prognosis. The outlook for GCTs depends on the type of tumor and how early it's caught. Non-seminomas with good prognosis have a 5-year survival rate of 92 to 95%, while seminomas typically have a better prognosis. Advanced stages or poor prognosis can lower survival rates, but overall, testicular GCTs are highly treatable. In summary, while germ cell tumors are rare, they are the most common type of cancer in young men and women, especially in the testes and ovaries. Most patients can be cured with appropriate treatment, which often includes surgery, chemotherapy, and sometimes radiotherapy. Early detection is key to improving survival outcomes.